All right, well, good afternoon, everybody, and thank you so much for being here. My name is Rich Botner, and I'm an assistant professor of internal medicine at Dell Medical School in Austin. I am a physician assistant by clinical training, and for the last 4 years, I've been leading our hospital-based opioid use disorder treatment program, and have the honor and privilege now of working closely with the Texas MOUD team in the development of SHOUT Texas, support of hospital opioid use disorder treatment, so SHOUT Texas, which is a program designed to help other hospitals in the state sort of learn from what we've learned and to provide assistance, consulting, educational opportunities so that other hospitals can follow in our footsteps. We've learned a lot in the last several years of doing this work, and it is truly an honor to be able to share some of those lessons learned, not just today, but over the course of this entire webinar series, and moving forward into our ECHO series and a number of other opportunities that we'll talk through. So today is webinar 1 of 5. We're really excited about this opportunity to, again, share with you a little bit about our journey, share with you the importance of this work, and really lay the foundational framework for what will ultimately become the ECHO series, which starts in June. So let's get to it. And I'll add, if there are questions at all today during the course of the program, go ahead and put those in the chat box. You don't have to wait until the end to do that. So you can put them in the chat box at any point during the program, and I'll try to address them as we go. But then at the end, of course, we'll leave some time for Q&A, and we can take you all off mute and have some dialogue and discussion. All right, let's get to work. I have nothing to disclose. And so today, again, as part 1 of this series, we're going to lay the initial groundwork. So we're going to talk a little bit about statistics of the opioid crisis and how those statistics relate specifically to patients who are hospitalized. We'll talk about some epidemiology. We'll talk about in-hospital mortality. We'll talk about some of the infectious complications of opioid use disorder and intravenous drug use. We'll talk a little bit about the fiscal impact of the opioid crisis, specifically on hospitals. This will help inform if there's hospital administrators on the call today, or if you are presenting more of a business case to hospital administrators at some point, you'll be empowered to share some of that fiscal information. And then, of course, we'll talk about costs from different perspectives, including things like readmissions and total cost of care. All right, so let's talk a little bit about a brief case, and I think this will probably resonate with all of you. And it's the case of a 42-year-old person who has opioid use disorder. His mom passed away at age 52 from alcohol and hepatitis C cirrhosis. He has spent more than 20 years in and out of prison related to substance use. And he's admitted to your institution, to your hospital, to your care for his 3rd episode of endocarditis. His treatment plan includes 6 weeks of intravenous antibiotics, but 2 weeks into this long hospitalization, he is found to have used heroin. So he left the hospital in the middle of the night, or a visitor brought heroin to him, and so he's found to have used heroin during his hospitalization. And as a result of this, there's sort of an escalating discussion and arguments between him and the clinical team, the physicians, the nurses, the social workers, and he's accusing everybody of not treating him appropriately, of not treating his withdrawal symptoms well. And essentially, he threatens to leave the hospital against medical advice, or what we would call a self-discharge. And so my question as we embark on this journey together is, what would you do in this situation? And does this brief case sound familiar to a case that you may have had recently? And I imagine that if y'all work in hospitals here in Texas, that the answer to those questions are yes. So we're going to ground the rest of the discussion today in that case. Overdose deaths continue to increase. This is some of the latest data that we have, and this graph I think is laid out very well to illustrate the importance of this topic. So we adapted this from the New York Times. I will have some more recent mortality data in one of the upcoming slides. But what I want to tease out here is that when you look at the 2017 data, the number of overdose deaths in the United States related to drug use and misuse far surpassed the peak of the gun violence epidemic, although you could argue that that is a re-emerging epidemic, but that the peak of gun violence deaths in 1993 and the peak of HIV/AIDS deaths in 1995. The way that we used to frame this was that drug overdoses, of which of the 70,000 number that you see on the screen, about 42,000 or so were directly related to opioids in 2017, that really this was the public health crisis of our time. That's how we used to frame this. Of course, now with COVID, there are competing priorities on the public health agenda. And what you'll see as we go through some of the content today, COVID has made it extremely challenging to continue to make progress in relation to drug overdoses and mortality, morbidity and mortality. And so now we have two public health crises that are sort of colliding together, and it's catastrophic for our patients. So this trend that you're seeing on this graph, unfortunately, actually hasn't gotten much better. So again, gun violence deaths in 1993, and then you see the same thing happening in 1995, and now we're here in 2017 and beyond. In 2021, as you'll see shortly, it's over 80,000 deaths. And it's important to tease out that a lot of the attention that we have been paying towards the opioid crisis over the last many years has been around prevention efforts. And this is a theme that we'll come back to several times over the course of the content today, that we've been focusing on sort of tightening the supply of legal opioids. So it used to be, quite common that you would go to see a primary care provider or a prescriber, and you would walk away with 50 to 100 or more oxycodone or hydrocodone with little to no scrutiny, right? And of course, we all know the stories of the Sackler family and pain is the fifth vital sign and all of those sorts of things. And so our immediate reaction when we started to make the opioid crisis a public health priority was to decrease the availability of those legal opioids, right? So that you couldn't go and get 100 pills of oxycodone. And I want to be clear that there's some controversy around there, right? That there are patients who have chronic pain, who have been under appropriate medical supervision, and who have done okay on opioids, who truly do not have a diagnosed opioid use disorder. They do not have an addiction to opioids. They are undergoing appropriate medical care for chronic pain. And those patients have been adversely affected. And so I want to be clear that this is not a very straightforward solution that we've come up with. But nonetheless, we have as a community, as a medical community and a public health community, we have said that we want to prescribe less opioids overall. And we've put in place all sorts of guidelines, even legislation in order to do that. And so what you're seeing on the screen is progress around that. And so you're seeing that we are prescribing less opioids, less morphine milligram equivalents per day than we were, even five years ago. So there is progress being made in that regard. But the question that we have to ask then is, if we're making progress in prescribing less opioids, then why does the number of opioid overdose deaths continue to increase, right? So what you're seeing on the screen now is data showing sort of the first couple of decades of the opioid crisis. And there is some progress that you see being made here, but really, as you see all the way on the right, when it comes to synthetic opioids, which primarily is fentanyl, you can see that the incidence and prevalence of overdoses related to that are just massive. And I can tell you this has not gotten any better. When we first started doing this work in Texas 4 years ago or so, I mean, fentanyl was here, but we didn't see it quite as much as we do now. Now fentanyl is everywhere, and people think of fentanyl as a substance that you inject, or maybe the heroin has been cut with some fentanyl. And there are lots of really good podcasts and articles that I can recommend that kind of explore this issue further. But the point is that fentanyl is now everywhere. So there are oxycodone pills, for example, that are manufactured outside of the United States illicitly, that are actually manufactured with fentanyl instead of oxycodone, because the fentanyl is easier to come by and less expensive to manufacture. And so if you're buying illicit opioids on the street, and you're some people may look to do something less risky. So instead of intravenous drug use with something like heroin, they may prefer to purchase pills. And so they purchase oxycodone, or what they think is oxycodone. In reality, they're purchasing fentanyl. And as you can imagine, if you're taking what you think is a 10 milligram oxycodone pill and it's actually straight fentanyl, that is a recipe for absolute disaster. And that's what we've been seeing. And of course, it's not just opioids. There are benzodiazepines, for example, that are being sold as benzodiazepines, but they're again actually either fully fentanyl or laced with fentanyl, because it's so much less expensive to manufacture. So this really is a crisis. It's not just heroin; it's the synthetic pieces too, like fentanyl. And again, this is increasing. And what I really kind of want to drive home here is, pay attention to the order of magnitude here on the y-axis, right? And so when you sort of look at 2015 to 2017, and then subsequent years data as well, the order of magnitude and sort of the exponential explosion of overdose deaths is really, really devastating. And, it's important to recognize that there are different waves, there have been different waves. And this is actually just a little bit outdated, because now there's a fourth wave, which I'll talk about in just a minute. So wave one was a rise in sort of prescription opioids. We talked about this a little bit earlier. This was during the time of sort of pain is a fifth vital sign. This was a time of the Sackler family and Purdue Pharma really pushing opioids as a safe alternative. And one that can treat pain and not cause any sort of safety issues for patients. And it really is a fascinating story how we got in the situation we're in now, and it reflects many failures within our healthcare system across numerous stakeholders. So if you get into the literature around how did we end up here over the last 30 years, plus 50 years really. There's lots of finger pointing, and I will tell you that at the end of the day, the finger pointing doesn't do any good, because every single one of the stakeholders who's pointing fingers at someone else, everybody's culpable, right? So this was a complete and total meltdown failure of all healthcare disciplines, right? Physicians, PAs, nurse practitioners who were prescribing, pharmacists who were dispensing, medical educators who were teaching, residents and students and PA students and nursing students, regulators, legislators, healthcare administrators, so forth and so on. So this really was a complete failure of the healthcare system to recognize that something incredibly dangerous was happening, and then putting safeguards in place to, one, mitigate it, and then two, prevent it from happening again, which we are sort of finally doing over the last few years. So that all kind of started during wave one, and then wave two started when we started to sort of tighten that supply. We started seeing more heroin being used. And then as we started to come up with technologies and ways to manufacture fentanyl, in particular fentanyl that was coming from China, now much more of it's coming from Mexico. But again, these are substances that are easy and inexpensive to manufacture. And now in wave four, it's stimulants, right? So you may appropriately say, in Texas, we have a larger issue with stimulant use than we do with opioids, and you would not be wrong in saying that. So we're not going to be talking much about methamphetamine today, but that is an important topic, and there is an abundance of research going on now to determine what is the best approach to help somebody who has a stimulant use disorder. And unfortunately, the science is far behind with stimulants as compared to opioids and other substances like alcohol, which we'll also touch on in just a bit. Okay, let's shift focus a little bit. I mentioned that during COVID, that overdose deaths have gotten just so much worse, and I'm just going to share a little bit with you about that. So here we have drug-related deaths. This is from 2019 through the first quarter of 2020. And what you're seeing is the increase in overdose rates in certain states across the country. And this is sort of in that same time period from the year before. And what you're seeing is that in many parts of the country, and you'll see Texas is on this list, that drug-related deaths are just skyrocketing. And there's a number of reasons for this, right? One, probably the most kind of obvious one, is that the physical isolation needed to combat COVID-19 and is effective for combating COVID-19 is extremely detrimental for people with substance use disorders, right? Social isolation is one of the driving factors of ongoing substance use, right? Not being part of a community, not being connected. And that's basically what we were asking people to do, certainly within the first 6 months of the pandemic, and really within the first year, and to a certain extent, even now. And so that is, you're certainly seeing that isolation reflected in these overdose deaths. You're also seeing lots of effect in terms of ability to get access to programs. So many of these programs that support people with substance use disorders, now a year later, after the pandemic came to the States, we have figured out ways around some of these barriers. We have, Zoom meetings, and many of these clinics are of course now open again to in-person visits, but that wasn't the case early on. And so it was sort of a double-edged sword that people's substance use was worsening in the presence of isolation, and then they couldn't get the help that they needed as a result. And so, of course, we're going to see a large increase in overdose deaths, and that increase was so stark and so important that the CDC issued an urgent alert across the health alert network. And this is not something that the CDC does frequently, issue these health advisories. And so in December of last year, they issued one. I'm just going to read a piece of this because it's really impactful and important. And again, they don't do this frequently. And so they basically said that the data that they were evaluating indicated that approximately 81,230 drug overdose deaths had occurred in the US in the 12 months ending in May 2020. So you saw in that kind of first slide that in 2017, we were sort of in the low 70,000s in terms of deaths. And now, here we are 4 years later. We would hope, having made progress, and in reality, we have not. We've gone backwards, and we have 10,000 more deaths. So this represents a worsening of the drug overdose epidemic in the United States, and it is the largest number of drug overdoses for a 12-month period ever recorded. So we've been sort of trying to address the opioid epidemic for the last decade plus, and that this is the largest amount we have ever recorded, period, in the history of all of this data. And the CDC has been collecting this data for obviously a very, very long time. So again, just really driving home the importance of addressing this as a urgent public health crisis. Okay, and then finally, I do want to just sort of share two more things with you. One is a program called ODMAP, so Overdose Detection Mapping Application Program. And as you all know, CDC, it does take them quite a bit of time to get data out. Actually, this data that you're seeing from this health alert network, that actually was sort of a unofficial release, in the sense that it's not final data, right? It takes the CDC well over a year to publish final data. And of course, in terms of responding rapidly as a public health system, that doesn't really work well. And so researchers came together, they developed this program called ODMAP, and ODMAP connects with 911 systems and EMS. There are several regions in Texas that are engaged in ODMAP. You can Google it and go to their website. They're doing some really interesting and impactful work, but it allows them to get data in real time about overdose calls that EMS is dispatched to. And so you can really start to get a sense, for example, if there's a particularly dangerous batch, for example, of illicit substances that are in the community, you can track that closely, and then you can send appropriate resources. So again, what you're seeing in ODMAP is what you're seeing with CDC, which is increasing overdoses over the course of 2020. And in some places, right, this is in the Delaware region, but in some places, right, we're seeing double, right, over 100% increase in substance overdoses, opioid overdoses in particular, directly related to COVID-19, right? So this is pretty impactful. Now, some folks might say, well, I've heard a lot about this. I've seen a lot on the news about all of this, but Texas, we're not really that bad. And this is data from the CDC in 2017. The darker the area, the higher the overdose death rates are. And what I would encourage us to kind of think about here is, when you look at Texas, we're basically the same as Nebraska and South Dakota. But when you look at all of the neighboring states to us, they're much darker in color than we are in Texas, right? And of course, as you can see on the map, and we all know, we share a very large border with Mexico, which is where a lot of these substances are coming in from. And so you have to ask the question, maybe the data is a little bit off, right? And I think from what we are all seeing in our own practice and in our own hospitals, it certainly doesn't seem like Texas doesn't have a problem, right? It certainly seems like our patients are struggling with substance use disorders and intravenous drug use, opioid use disorders. And there's some possible explanations for this. And think about how this data, so the CDC gets their data from the state. The state gets their data from the county, and the county gets their data from municipalities. And we can talk a lot about overdose data and mortality data, but I would sort of just included this here so that if, in case someone says to you, well, we don't really have a problem here, you'll have something to respond with, which is we do. Now, part of this explanation is in the fact that many of our counties in Texas do not have a medical examiner. They have a justice of the peace who certifies the death. Now, I'm not knocking justices of the peace. They do have training in order to do the job that they do, but of course, it's not the same as a pathologist training. And more importantly, the fact that many of our counties have JPs and not medical examiners is more a reflection of the population density and therefore the tax base and the resources available. So it signifies a county's ability, or lack thereof, to have the ability to send a toxicology study or to do a formal autopsy. And so many of those deaths, which may actually be respiratory arrest or cardiac arrest related to substance use, the substance use piece doesn't get documented. And so when the municipality sends that to the county and the county sends it to the state, it's not coded as being drug related. And so that's part of the explanation. I'm sure there is more to it, but that's part of the explanation as to why some of our data may look a little bit different. And the data doesn't necessarily connect with other data that we know. So we have access to, for example, data from organizations that staff ERs, right? Professional organizations, physician organizations. And they have their own data where they track the number of encounters that their physicians are seeing, right, for billing purposes. And if you just look at that data alone, it would suggest that we're seeing more patients in our ERs with opioid use disorder than we're seeing in the community, than we're seeing in this data. And of course, you would expect to have a higher mortality number as a result. The answer is not that as a state, we are treating substance use disorders better than the other states. In fact, we have many challenges in Texas, which we'll talk about over the course of our program together. The most recent data that we have, which is from May of last year, which is sort of specific to, again, synthetic opioids, which is primarily fentanyl, actually shows that Texas does have a problem. So even in the absence of having a robust infrastructure in every county across the state, of course, remember, Texas is a huge state. We have many, many counties. And so despite having some variation in practice across the state, we still are showing in our data that we have large increases in synthetic opioid overdoses. So you'll see kind of the whole southwest of the country is really struggling with this, greater than or equal to 50% increase in a 12-month period. And again, this is related to fentanyl. I want to pause. I mentioned this earlier. I said a little bit about methamphetamine and stimulants, and I mentioned just a tiny bit about alcohol. It's not just opioids. The content that we're going to share over the next 5 sessions and in our subsequent ECHO series is really going to be focusing mostly on opioid use disorder and how to effectively use buprenorphine in the hospital setting. But we have to remember that most of our patients have comorbid substance use disorders. Alcohol use disorder is probably the number one in terms of morbidity and mortality and cost of care, not just here in the state, but across the country. And again, stimulants are a big issue too. So I don't want you to walk away from this content thinking that opioids are the only and biggest problem. It's really a mixed bag. And so we have to sort of think about how do we approach this holistically, even though this content is really going to be specific around opioids. All right, let's shift focus just a little bit. I want to make sure that one of the things that we're sort of talking a lot about here are the different reasons that people get hospitalized related to opioid use and misuse. And when you go to sort of general meetings about this, when you go to meetings with public health experts or even with hospital administrators, the conversation tends to center around overdose, right? Even the data that I just presented to you tends to focus around overdose, and it tends to focus around mortality, right? So as a country, we really sort of harness focusing on mortality, how many people have had an overdose and subsequently died. And when we focus on hospital data, we tend to focus on how many patients were transported to the ER as the result of an opioid overdose. That is the wrong way to look at the data in order to determine the business case, right? Mortality is important, absolutely. But when we talk to patients that we see in the hospital, they actually rarely talk, when we ask them sort of, are you interested in buprenorphine therapy and what are your goals for treatment? Rarely do patients say, I don't want to die. Now, I'm sure they don't want to die, and that does come up in our sort of subsequent encounters. But in those early meetings, it's rarely about mortality. It's about having a certain quality of life return that they didn't have before. It's about having stable housing, about getting a job, about reconnecting with their family, maybe their children. That's what they often talk about. And so, of course, death related to opioids, that's a huge problem. And I want to be really cognizant of noting that, earlier we're talking about 70,000, 80,000 deaths. Every single one of those 70,000, 80,000 people is someone's spouse, someone's brother, someone's sister, someone's child. So these are individual lives, and the ripple effects for any one of these deaths is huge. But when we think about it as a hospital, we have to think about it more broadly. And so patients come to the hospital as a result of opioid misuse for a number of reasons beyond just overdose. And by the way, many people do not transport to the hospital after an overdose, right? There are lots of patients who are revived in the field, either by EMS or police initiated naloxone or bystander naloxone, and then they don't get transported to the hospital. So the people that we see in the hospital are people who have maybe had a severe overdose, so that they're not revivable in the field. They may self-present and say, I want to stop using, and they may exhibit symptoms of withdrawal. But symptoms of withdrawal may also exhibit by themselves when patients are admitted to the hospital for any number of other reasons, whether it's directly related to opioid use or not, right? So if we have intravenous drug use, we are potentially going to have bloodborne infections, in particular hepatitis C. So hep C, we've had over 100% increase between 2004 and 2014. And of course, there's all sorts of downstream effects of untreated hepatitis C, which ends up in hospitalization. So it's not uncommon for us to have a patient who has hepatitis C cirrhosis, who presents to the hospital for management of liver failure, so forth, and during hospitalization may experience withdrawal, may be asking for help related to opioid use. We know that illicit substance use can lead to high-risk sexual encounters. And so there are subsequent things from that, such as HIV transmission, and then again, hospitalization related to the effects of HIV. Of course, endocarditis is one that we often talk about. 100% increase between 2002 2016, over 200% in some areas. And these are expensive, prolonged hospitalizations, right? Patients spend part of that hospitalization in the ICU, 6 weeks of intravenous antibiotics, 6 weeks in an acute care bed or at a skilled nursing facility. This is a major, major, major important thing to talk about within our health systems. Not to mention the number of skin and soft tissue infections and the role of imaging in all of that. And so the infectious disease consequences of intravenous drug use have gotten to be so important to talk about. The numbers are so high that the IDSA, the Infectious Disease Society of America, has actually called on a sort of dual subspecialty where infectious disease doctors would actually be trained in not just infectious disease, but also in addiction medicine. I can tell you at our institution, so many of the consults that we provide to our infectious disease consultants and colleagues are a result, direct result of intravenous drug use, right? And much of this intravenous drug use is related to opioids, heroin and fentanyl. And of course, we talk a lot about readmissions in all of these different circles. And so it's important to note, patients with substance use disorders are more likely to be readmitted within 30 days. And what's amazing about this is a study from 2012, that even when adjusted for age, for sex, the presence of depression, insurance status, housing status, and Charlson score, which is a score of how severe comorbidities are during hospitalization, even when you took all of those off the table, substance use disorders were still sort of an independent predictor of whether or not a patient would be readmitted within 30 days. So 1.7 more likely to be readmitted compared to people without substance use disorders. And again, if you have opioid use disorder, more than 1 out of every 10 is readmitted within 30 days, right? So when we think about hospital medicine, when we think about what's going to get administration engaged in programs like this, oftentimes the holy grail here is readmissions. And this is actually how we started doing our work at Dell Medical School, was around readmissions, was doing quality improvement work, trying to figure out which patients were at the highest risk for readmission, discovering that it was people with substance use disorders, opioid use disorders in particular. And that's how we started doing this work. Of course, subsequently, we recognized how truly important this was to clinical care and to the way that we were treating people. But early on, in the early conceptual stages, it was about readmissions. And so you can make a compelling case for cost savings and institutional involvement based on readmissions, but you can also look at it based on sort of total cost of care. We know that people with opioid use disorder cost healthcare systems at least 8 times more than patients without. And again, that probably has a lot to do with length of stay and comorbidities as well. There was a study by the Society of Actuaries where they determined the economic burden from opioid misuse was over $630 billion just in a 3-year period. Now, when they do these studies, they incorporate a lot of different pieces. So they look at sort of healthcare costs specifically, which was about $200 billion. They look at lost wages and lost productivity. And then they look at what happens as a result of incarceration and sort of lost productivity related to not being in the workforce, but also the cost of incarceration itself. And we will talk more about the intersections of criminal justice for people with opioid use disorder in one of our future webinars. And then there was a recent study that the cost associated with OUD specifically is about $11 billion annually, and it represents 1% of all hospital expenditures. So 1% is pretty significant when you think about all of the different expenses that hospitals have in terms of staff, in terms of regulatory environment, plant and operations, upkeep, all of those things. So 1% to a single diagnosis is very large. And for many of these patients, hospitals are not recouping the costs. So if you can develop a program where patients are receiving, one, higher quality care, which is something we all care about, but as a result, reducing expenses through reduced readmissions, reduced length of stay, so forth and so on, that's a win-win for all stakeholders involved. All right, this is kind of a busy one here, but again, I think what we're really trying to drive home here is that the cost is just exponentially higher for people with opioid use disorder than those without. And even in this study here from 2016, that when people were even when people had a regular sort of appointment, a regular primary care appointment, within 30 days of a hospitalization, they had a substance use disorder, they still had a relatively high risk for subsequent issues within 30 days of discharge. And that has a lot to do with care coordination or lack thereof. And so as we go through our content together over the next 5 sessions or 4 sessions after this one, we'll talk a lot about care coordination and how important that piece is of building bridges in the community. All right, and then finally here, patients admitted for an opioid overdose had a lower odds of being engaged in SUD treatment after discharge compared to other substance-related diagnoses such as alcohol use disorder. So we have built systems of care for other substance use disorders outside of opioids. Those systems are also extremely fragile and incomplete. But for opioid use disorder, in Texas, there are a number of challenges, right? We have a fairly limited number of slots for methadone. So at our institution, we can't start people on methadone during hospitalization because there's a 6-week wait list when patients discharge. And I cannot legally prescribe methadone for the treatment of opioid use disorder when patients discharge. Extended release naltrexone has some very strong clinical data and trials behind it, but it's over $1,000 a month. And so if you are a underfunded or unfunded patient, again, extremely hard to access. And that leaves us with only one other FDA approved medication for opioid use disorder treatment, and that's buprenorphine. Buprenorphine, relatively inexpensive, and the beauty of buprenorphine is that it can be prescribed by anybody who has that X-waiver training, which we'll talk a little bit more about in future sessions. But the whole idea behind buprenorphine was that it can be offered and administered in any practice setting, primary care, women's health, so forth and so on. And so that is really the focus of our time together, and potentially at least partial solution to this public health crisis. So in your institutions, as I mentioned earlier, there's probably a good chance that you are focusing on prescribing. You probably have an opioid steering committee of some sort. You've probably paid a lot of attention to prescribing practices. There's new Texas laws about how much you can prescribe and for how long. And so people are really paying attention to this. But I want to pay attention to this study from 2019, which essentially said that, yes, interventions around prescribing are important. They are part of the solution, but we have to think about things holistically. So we have to include treatment, we have to include harm reduction, we have to include education. And if we don't, if all we do is focus on improving our prescribing habits, at best, we will improve the overdose environment by 5% by the year 2025. So I mentioned earlier that we had 80,000 overdose deaths in the 12 months, May 2020 and the 12 months preceding. So if we reduce that number by only 5%, that's embarrassing, right? We'll be in the high 70,000s, which is still higher than we were in 2017. And we will not have made many progress. And again, every one of those deaths represents a life. It represents somebody's family member or friend. And so we have to do better. And the way that we do better is by being holistic, is by having treatment and harm reduction and all of the things that we're going to talk about and learn together over the next several weeks and months. So what's the steady state? What happens now at most hospitals, not just in Texas, to be very clear, this is not a Texas problem, this is a US healthcare problem. So what happens at most hospitals in the United States when a patient presents with opioid use disorder and they're experiencing withdrawals? Well, you know, the science behind opioid withdrawal is actually pretty straightforward. We teach it to medical students and residents in a matter of 30 minutes or less. And the way that most hospitals approach it is by providing sort of symptomatic relief, right? So we use medications like clonidine, we sort of help to bring some of that anxiety down. We use medications like hydroxyzine for the same thing. We use antiemetics to reduce vomiting. We use anti-motility drugs to reduce diarrhea. But we don't actually treat the withdrawal itself. We don't treat the underlying problem, which is the opioid use disorder. All we do is sort of symptom control. And we know a couple of things about that. One, we know that symptom control based on sort of our current practice as a medical community is not so great, right? Some patients do okay with hydroxyzine and clonidine and Zofran and all of those types of medications, but many patients do not. And those are the patients who we typically find self-discharging, right? And there's nothing worse than a self-discharge during these hospitalizations because, one, most importantly, there's a reason that patient was admitted to the hospital. They had some sort of acute crisis, acute medical condition, and they are leaving before that medical condition has been resolved. So the likelihood of that condition getting worse and posing a risk to that person's life and resulting in a subsequent readmission, all of that is very high. So self-discharge is bad for the patient. It's also bad for the providers, right? Providers who feel very frustrated that they couldn't do something more for that patient. And of course, it's bad for the system, right? There's a lot that goes into a hospitalization on the front end. There's imaging, there's provider time, there's of course nursing time and other staff member time. So there's a huge expense that goes into hospitalization. And if patients leave before their medical treatment is complete, you could argue pretty well that all of that expense, all of that resource that was allocated was sort of for naught. And so in the moment, we tend to feel really good about starting some of these medications because for some patients it helps, and we say, okay, we got that person through their withdrawal, we sort of fixed the acute problem, we give ourselves a pat on the shoulder, and we feel good about it. But what we know is that when we do that, when all we do is sort of treat the withdrawal symptoms, that 80% of people who use illicit opioids will be back to using within 30 days of discharge when we don't provide anything else, when we don't provide a treatment, when we don't address the underlying problem, which is the opioid use disorder, right? So even if you take sort of a very, I'm going to say the word basic, but I don't mean that negatively. If you take a straightforward, basic abscess, a patient with an abscess who's admitted for 48 hours, right? So two midnight stay, even a 1 midnight stay for some folks with abscesses, right? And so we do the clonidine, we do the Vistra, all that kind of stuff, and then patients leave and we feel relatively good about it up until 2 weeks later when that patient returns for the same problem, right? And the question is, could we have done something different? Could we have addressed the medical problem, the abscess, so forth, while also addressing the underlying issue, which is the substance use disorder or the addiction? And I want to pause and make a very important distinction. We do not advocate for, and we do not practice at our institution, the idea that hospitals should be treatment centers. That's not the goal of this program or our program. We need to build better, more robust outpatient infrastructures to support substance use disorders, which is happening. That being said, people present to hospitals for acute crises, acute, life-limiting, life-threatening crises. And addiction fits the bill. Addiction is a life-limiting, life-threatening crisis. And so while we don't advocate by any means for hospitals to provide ongoing addiction treatment for patients, just like we wouldn't advocate for hospitals to provide ongoing treatment for diabetes or heart failure, we do expect hospitals, and we do call on hospitals to be more engaged stakeholders in this continuum of care. There's no reason that a patient with opioid use disorder who's using intravenous heroin should not have that as one of the problems we address as part of hospitalization, and set that patient up for success at the time of discharge. And the best sort of parallel here is diabetes, right? If a patient is admitted with a blood sugar of 450, even if they're admitted for the third time in the last month for a blood sugar of 450, we're going to provide counseling. We're going to provide a prescription for insulin. Even if we provided 2 previous prescriptions, we're going to provide another one. We're going to make sure that that patient has an appointment when they leave the hospital to follow up with a provider in the outpatient world. And we're going to do everything we can to support that patient, bring that blood sugar down, and set them up for success, right? We don't discharge that patient with the anticipation that they're going to come back and we're going to give them insulin every day, right? We set that patient up for success. We provide that counseling, that coaching, and that medication. And that's the same thing we should be doing for substance use disorders. And in this case, it's what we should be doing for opioid use disorder. So, hospitalization is a recovery opportunity. We know that up to 30% of patients leave the hospital against medical advice, what we call self-discharge. And that happens for a number of reasons. It happens for inadequate treatment of withdrawal. It happens for fear of mistreatment by the staff. It happens for cravings of opioids that are unaddressed. And it's important to note that hospitalization is an important reachable moment. So patients are away from triggering environments. They are hopefully surrounded by a supportive, caring staff. And so it really is an opportune time during this, hopefully short period of hospitalization can also be a healing period. And so if we're going to address the medical issues, it certainly makes sense that we should be addressing the underlying issue, which again is the substance use disorder. And just to give you a sense of how well this could work, there was one study out of Pittsburgh, and they randomized folks. They randomized folks with opioid use disorder in the hospital setting. Some were basically given a sheet of clinics that they could go to at discharge, and they did not have any other resources provided regarding their opioid use disorder, right? I would call that the current state at most hospitals in the country. So they got a sheet from the social worker that said, here's where you can go, good luck to you. And then the other half of the patients were randomized to start buprenorphine during hospitalization. And it wasn't like some sort of super fancy, hand-holding algorithm, this and that. It was pretty straightforward. They were seen by a researcher who was either a addiction psychiatrist or a psychiatric nurse practitioner, which, by the way, you do not need those disciplines to initiate buprenorphine. We're all going to learn how to do that together in a very straightforward, easy way. It is not a dangerous medication. It's a very safe, straightforward medication to use. And we'll talk about that in a future session. But they were randomized. They were started on medication during hospitalization, and then they were discharged to a specific clinic. And 72% of the people who were randomized to start buprenorphine in the hospital followed up with that outpatient clinic after discharge. 72%. What percentage of the patients who were not provided buprenorphine, who were just provided sort of the list of clinics, what percentage of them do you think made it to the follow-up clinic? 12%, right? So when we address substance use disorders in the hospital, there is so much that we can do downstream for our patients. I can tell you for our work here in Austin, where we've empowered primary teams to do this work, our follow-up rate is about 60%. And the difference between our program and the one that's studied here is the one that's studied here, they had some research assistants that could do some more direct sort of hand-holding and facilitation. Our work is actually about to be published in Journal of Hospital Medicine. And when that happens, we'll of course share it with all of you so you can sort of just see a little bit of our data. But when you look at programs across the country, that's about where they fall. Somewhere between 50 and 70% is the follow-up rate after hospitalization. And I would argue that for many of the diagnoses that we see in the hospital and for the patient population that we serve at our safety net facility, 50 to 70% follow-up rate is pretty good. And our patients do well after discharge, and that's the goal. Again, this is another study where we looked at buprenorphine and opioid use disorder, 53% reduction in 30-day hospital readmission. Please show me anything else that we do in the hospital, any other intervention or quality improvement work that we do that reduces readmission by 53%. I don't know of anything, right? And so there's a lot, again, that we can do for patients. And then finally, I do want to just tease out a little piece of, this is going to seem maybe a little bit nuanced, but I think it's important. This is a study out of Vermont, and they looked at Medicaid expenditures and health services utilization for people with opioid use disorder, those who were engaged in a medication for opioid use disorder program or a MAT program, medication assisted treatment, which is a term that has fallen out of favor, and compared them to those who were not. And what I want to kind of drive home here is, if you look at the total expenditures, is this going to work? No, that's not going to work. Sorry, I'm trying to, let's see, how about if I use this one? If you look at, nope, that's not going to work either. Oh, there we go. Okay, so if you look at total expenditures, which is here on the first line here that I just put the mark on, you can see that the group of folks who are engaged in the medication for addiction treatment programs, they actually cost less, right? So they cost less than the folks who are not engaged. And one of the things that you'll often hear when you start talking about costs associated with these programs is, oh, they cost more, they cost more. And what people often confuse, and I want to empower you with the right information here, is they confuse this line right here. So they say, well, you know, the medication costs a lot more. Well, of course the medication is going to cost more than if the patient was not engaged in a program that provides medication. That makes perfect sense. And so when you look at the numbers, when you look at the cost, it's really important to think about this from a total cost perspective, right? Both inpatient and outpatient. And so what I think is really impressive here is that for patients who are engaged in programs, you can see that the inpatient cost is, again, far less than what you see for the outpatient. Sorry, my mouse drawing skills here are pretty terrible. But you can see that when patients are engaged in programs that their hospital costs are a lot less. And then when you look down here in this column here, they're spending less time in the hospital, right? They have less inpatient days, they have less ER visits. And so this is in Vermont. They have Medicaid expansion, right? So, you know, there's certain advantages perhaps over Texas, but the data is the data. And so as we continue to build these robust systems of care, these are the kinds of results that we can expect. And so if you're in a health system, if you're working for a hospital, if you're trying to sell this to a hospital administrator, there is significant cost savings to addressing opioid use disorder as part of acute hospitalization as a whole. Again, not saying the hospital is a treatment center, but being holistic in how we approach patients with substance use disorders during hospitalization. These patients with opioid use disorder are being admitted to your hospital already, right? This is not like we're creating a program where we're, attracting new patients. These are already patients that we're serving. We're just not serving them as well as we could. And that's the whole purpose of this program. All right, I'm going to kind of start to wrap up here. I'm not going to read this all to you, but this is basically revisiting the case that we started with. And, again, it's the case of someone that I think we are all familiar with. And so I would ask you, what would happen at your hospital today for a patient like this? And what do you want to have happen for a patient like this moving forward? And I imagine that the answer to that is improved system of care, and that's why you're here, and that's what we're going to be working on together. So moving forward, I just want to share a little bit with you about what we're going to be doing as the Shout program. One is we're going to continue this webinar series. We have 4 more, and this was really just meant to lay the groundwork. The next 4 are going to be more nitty-gritty about how do you actually start to formulate ideas to build a program like this at your institution. We're going to be having regular office hours. Those begin tomorrow, actually. And so those will be once a month. We're going to have an ECHO, a community of practice, that starts in June. And for those who are not familiar with ECHOs, they are virtual learning communities. So they're small group communities. They'll meet pretty regularly, potentially even as frequently as every other week. And they will provide case-based learning for all of you. There's no cost or anything like that. Really, this is all about increasing access to care, and ECHO is a wonderful model to do that. So if you've participated in ECHO before, you know how powerful it is. And if you haven't, we're excited for you to do that. And then we're providing, sort of direct consulting, or what we call technical assistance, for hospitals who are interested in doing this work. Consider me a resource. That is probably the biggest take home here. Nothing makes us happier than helping hospitals do some of the work that we've done at Dell. And so if there is anything at all that we can do to facilitate that work, that's what we are here for. So I'm going to go ahead and just real quickly in the chat box. So you have my email address is on the screen. This is my cell number. I turn my phone off when I go to bed, so you can call or text anytime, day or night. And if I'm sleeping, I'll get back to you in the morning, but otherwise I'll usually answer right away. So please consider myself and my colleagues a resource. And with that, we've got 1 minute left, but I am absolutely going to stay here past 1 o'clock. So if you have to jump off, I totally understand, but I'm going to open it up now to Q&A, and we will stay as long as it takes to answer all of your questions. So thank you all again for being here for the first session, and feel free to either unmute yourself if you'd like, or you can just put your questions in the chat box. Any questions? Thanks, Emily. Emily says that she's excited to learn more, and she's working with pregnant moms with opioid use disorder. Emily, would love to learn more about your work. We're actually in the process, literally today, of convening a statewide group of people who are doing exactly what you're doing. So if you want to email me, I would love to include you in those follow-up emails with that group. We're establishing a work group around this with folks from across the state. So yes, please email me, and I'll be sure to include you in that message. All right, y'all, we'll give it 10 more seconds, and then we'll close out for today. All righty. Well, thank you all again so much for participating and being here. And we look forward to seeing you on our next webinar. If there's anything I can do, please just let us know. Take care. Have a good rest of your week and a good weekend, and we'll see you soon. Bye-bye.